Alrighty, so before we move on to palliative care, I just wanted to make sure we had, number one, covered everything that you guys wanted to get covered in dementia, and also just point out some of the resources. So in the front of your packet are some of those communication tips, and then a couple of pages of websites and phone numbers for resources. So included under the other dementia caregiver resources, number 6 is the item for research projects being done at Washington University. There's a phone number and a website there. And they're doing research that enrolls patients or folks, even if you don't have dementia, but maybe you're just interested in being a normal control in a study, or maybe like me, you have a family history, and so you're interested in getting in and then being followed over time in case you develop dementia in the future. There are studies for folks who have been labeled with or been told they might have mild cognitive impairment. And again, a lot of people who are told they have mild cognitive impairment never progress to actual dementia. Some eventually do, like my mom, but that was over after 7 years of being very stable. And then there are research studies for folks who already have been diagnosed with some dementia. And some of the research studies I think they're doing there are actually treatment trials. So you could ask for you or a loved one about being enrolled in a study that might actually be testing a new treatment. So that's kind of number 6. Lots of other resources here. Were there any other kind of final questions around dementia before we move to palliative care? Yes, sir.
And maybe in those research links there. But what does current research say about what is genetic, what's already pre-programmed, and how much of this is conditional? What's the latest thinking on that?
I think that's a great question, and kind of the $60,000 question. So there's one rare variant of Alzheimer's that's autosomal dominant inherited, which basically means if it's a gene abnormality where if one of your parents had it, you've got a 50% chance of getting it. That's a much higher risk than just the more kind of usual case of Alzheimer's, which up to maybe 15% of folks 65 and over are experiencing at that time. So that's the rare genetic kind. And then there are other kind of risk factors, some of whom are a little bit genetic and some are, what is it about our environment? I was chatting with someone in the break, we don't know what cell phones are doing to our brains. We don't know all the chemicals that are in our food, the chemicals we've been exposed to. It still just looks like as much as you can practice good cardiovascular health, that's the one thing in observational studies that has at least been pretty consistent. Exercise, blood pressure control, cholesterol control, a diet rich in fruits and vegetables. Other than that, kind of teasing apart how much is genes and how much is environment is just really tough to know. Yes, sir?
Have you seen any studies in terms of the effect of the link of a person that takes Aracep or the Exelon pad or Lamictal, particularly on sudden dropping blood pressure?
So one of the side effects of that class of medicine, so Aracep and galantamine or Razidine or the Exelon patch are all the same class of medicine. One of the potential side effects of that class of medicine can be a slowing of the heart rate, which can cause passing out or a drop in the blood pressure. And it's just very patient, individual specific if you're going to get that side effect or not. It's why all of those medicines start with the low kind of half dose and to make sure the patient can tolerate the medicine, and you take that dose for a number of weeks and then you move up to more of the full dose. It's hard to predict ahead of time who's going to have that side effect and who may not. And sometimes you're not having that side effect, and then you get added another medicine that might drop your blood pressure, and it's kind of the combination of the two. Were you going to ask something else?
Well, I was just thinking over time, does the risk increase?
Of developing the side effect?
Yeah.
It's a great question, and it does really kind of in general for medicines. As we age, the other things that are gradually slowing down is things like our liver and our kidneys. And our liver and our kidneys are what clear medications. So really not specifically related just to dementia medications. I see a lot of folks who've been on a medication for many, many, many years that might have a side effect that might be something like sleepiness that never made them sleepy before, but because now their body's not clearing the drug as quickly, now they're starting to develop a side effect like sleepiness, even if you didn't change the dose of the drug. And that's true for any type of medication that we're taking. If we have another change, like our own natural aging process, or again, maybe we develop a new disease, or we have another medicine added, and all those things coming together, a patient can develop a side effect. It's kind of known in the geriatric field as the prescribing cascade. So a patient will develop a new side effect, and if the physician or the care providers don't recognize, well, that's really a side effect of another medication, they'll try to treat the side effect with another drug, and now you're on this vicious prescribing cascade. Yes, sir. Did you have a question?
Oh, just follow-up and clarification. I'm on a number of heart medications because of pacemakers. Do those things like Daxin, Sotalol, and all those others, do they get in the way of dementia treatment?
Not so much. What I always look for is if a patient's already on medicines, it's usually heart medicines that slow the heart rate. That's kind of their job. If I'm giving another medicine like Aricept that has the potential to slow the heart rate, I just monitor that very closely. In that early stage where I'm starting the Aricept at a very low dose, we always talk to the patient and family. Now, if you start to feel dizziness, then that might be a side effect. Call me right away. Now, if a patient is starting out with a heart rate that's already on the very slow side, then Aricept might not be the best option for them, or it would have to be monitored very closely. So those are really a lot of those very individual specific conversations to make sure you're having with your doctor. All right, so are we kind of covering what folks came for around dementia? Yes.
That one thing that you were talking about, the rare gene, is there a test? I mean, like, is there a blood test? I mean, how would we know, like, my dad has it, so, I mean, how do I know if is it the rare gene, or is it his diabetes that caused this, or?
So some of these research studies would be the way to get at that at WashU. Those are usually very remarkable family histories. They're usually family histories where everybody in my family starts getting Alzheimer's in their 40s. And it's widespread. It really stands out. It's not the typical, starting in 60s, 70s, 80s, we start to develop dementia. That's not this very rare. This really autosomal dominant genetic defect is a very rare thing. Yes?
Are patient families coming in with their 23 and results?
They may be. For my own practice, I only work in the hospital, it would not surprise me. Yes. All right, so I wanted to be sure we got to palliative care because I know that was another specific request. So I want to thank my colleagues from the Southeast Institute for Innovation in Palliative and Supportive Care. It's a mouthful. At UAB, but UAB has a very robust palliative care program. They train health systems from across the nation, and they have taught me what I know about palliative care. So Jackie Palmore is our nurse coordinator and a couple of our docs there, so they provided a lot of this content that's coming for you today. So this is kind of what I have a few slides on this, and then again lots of time for discussion and Q&A at the end, and that'll kind of finish out our day. So we'll have plenty of time for conversation. I don't have as many slides. So we're gonna answer these right now. I'm not going to tell you the answers, and then we'll loop back around at the end. But just think about, once you elect palliative care or hospice, you can no longer see your primary doctor or subspecialist. Is that true or false? How many folks say that's true? Think about that. Receiving palliative care means you can no longer receive curative treatment at the same time, such as chemotherapy. How many think that's true? Think about that. Okay, good. Hospice patients do not resuscitate. They must say, I don't want to ever get CPR or go on a ventilator. Think about if that's true or false. Palliative care or hospice are appropriate only for those who are going to die soon, like within the next month. Think about if that's true or false. And then hospice provides family with up to a year of bereavement counseling after a patient's death. Think about that. So we know that's true. We have an expert. Perfect. All right, we're going to come back around to these. And after we chat for a little bit, we'll be able to answer all these statements. So what do patients want when they're facing a life-limiting illness or injury? So that might be dementia, that might be heart failure, that might be you've just been in a horrific car accident with life-threatening injuries. According to the medical literature, patients want to be free of symptoms. They want their pain controlled. They want their symptoms addressed. If there's no hope of recovery, they don't want to unnecessarily prolong the dying process. Patients and families want to have control over what they are still able to control, and specifically around making decisions. Patients will say, I've already heard this from my mom, well, I don't want to be a burden to you guys. And we want to strengthen our relationships. And this is kind of a way to think about how we should live every day. But specifically, I met with a friend of mine this week who's just had a new diagnosis of cancer, and she flat said it really changes what's kind of the priority in my day, and that makes sense. So what do patients actually get? Well, they kind of don't get any of that stuff routinely in the American healthcare system. What patients and families say is they don't have enough contact with their doctor. They're not getting the emotional support they would like. They want to know more about what the dying process looks like and what they would want it to look like for them. And they need more help with their symptom control. So to address this gap in care, the medical subspecialty of palliative medicine was developed. Palliative care is basically care provided by a team of healthcare professionals, so doctors, nurses, and many others. I'll show you a list in a minute. And it brings in this extra layer of support for patients and families who are experiencing life-limiting illness or injury at any stage of that disease process. So the patient is still seeing their normal dementia doctor, their cancer doctor, their heart failure doctor, but palliative care is available to provide this extra layer of support. It's therefore appropriate at any age and any stage of the disease. It's not just for folks who are imminently about to pass away, and it can be delivered while you're still pursuing treatment to cure your disease. So if you've just been diagnosed with early stage lung cancer, you're pursuing chemotherapy or radiation or surgery to try to cure your lung cancer, but you're having a lot of symptom burden, either from the chemo or from the cancer, then this extra team, especially trained to manage symptoms, can come alongside. And that's what the palliative medicine team does. And so you can learn a lot about palliative medicine through this website, CAPC, Center to Advance Palliative Care. And there's the website link. It's also, I have several links in your handout around palliative medicine programs here in St. Louis area. But it's now an officially recognized medical subspecialty, but only since 2006. So for such an important need, it's only kind of been officially recognized as a subspecialty for about 11 years or so. So where does this term palliative come from? I will say the field has done a great job, but labeling itself palliative has probably created some confusion because nobody knows what that means. And the field has recognized that, and they're really a lot of times relabeling themselves as supportive care. So if you hear about supportive care, that's probably code for palliative care, just in language that folks can understand. But the term actually comes from the cloak worn by bishops or priests in the Catholic Church. Therefore, it's derived from a term meaning to cloak or to shield from the violence of illness or injury. So that's where the term palliative comes from. So who are members of this palliative team? Hospice, I'll show you this in a graph in a minute, but hospice is sort of a component of this type of care, of palliative care. And the patient and family are always at the center, and this is really a team approach. So in any of the various types of palliative care programs across the country, whether they're working in the hospital or in the clinic or in the home or in the nursing home, the focus really is on whole person care, including emotional and spiritual care. So you mentioned, I think, music therapists, pet therapists. So all these folks are members of our palliative care team at UAB and at many palliative care teams across the country, really bringing that whole person care around all the domains of suffering. So the field also works with children, either children who are experiencing the life-limiting illness themselves, or children who have a parent or a loved one who may be experiencing this or who may be passing away. So really a team approach, including our volunteers. So thank you very much. So traditionally, we kind of think of the doctor, and a lot of doctors still think about this too, although this is getting much better, is the doctor is there to treat the physical symptoms, the pain, the nausea, the anxiety. But palliative care really approaches all the domains of suffering. And all of these feed on each other, so it's very important that we look for and address all the domains at the same time. So social suffering, an example would be, if I ended up getting cut off from my friends and family because my mother 10 years from now needs 24-hour care, then I've had a social loss myself. I've lost that connection. So that's an example of social suffering. If that makes me feel depressed, then I'm having some emotional suffering. Does that make sense? Or if that makes me anxious, or if worrying about that makes me anxious now. A lot of times I'll have patients and families ask me in the spiritual suffering world, well, why did God allow me to get this diagnosis? Or, is God angry at me? One of my nurse practitioner friends who works at the VA tells very compelling stories about veterans who still feel extremely guilty about what they did in the Korean War or even in World War II, and that God can never forgive them. And this is coming out because now they're facing a life-limiting illness. Very compelling story. So we need all types of healing when folks are facing these challenges. Okay, so what is in hospice? Hospice comes from the same root word as hospitality. It's also where we get the word hospital. And hospice, again, came to Europe before coming to the United States, but essentially defined as an insurance benefit. So we think about hospice care when folks have a life-limiting illness or injury, and we think our best guess is their life expectancy is 6 months or less. That's what sort of qualifies them for the insurance benefit that then pays for the hospice team, which mirrors the palliative team, to then deliver the care to the patient, along with the equipment and the medicines that are needed for the hospice care. Did I get that correct?
Sure did.
Okay. Now, breathing treatments, oxygen, hospital bed. So equipment that it's needed in the home or the nursing home to promote the comfort and symptom management for the patient. Yes,
and
sir.
also nurses that are available.
And nurses.
24-hour call to come to the home.
Right.
And they provide some pretty sophisticated medicines that you can't get in the hospital.
Exactly. So when you get the hospice team, you kind of get full court press around aggressive symptom management. So the hospice team will go wherever the patient is living. So some people think, well, because my loved one's in a nursing home and not in a house, they can't get hospice. Hospice will go where the patient lives. So that's because that's their home. And the team is made up of the same folks around that circle before. So usually a medical director that works with the patient's own doctor, primary care doctor or cancer doctor, dementia doctor, nurses, social worker, volunteers, pet therapists, music therapists. And the focus is on what's beneficial and not burdensome for each patient at every stage of their disease. And what's beneficial is managing symptoms. And the hospice nurses have all kinds of ways to deliver medicines to patients who maybe can no longer swallow or who don't want an IV anymore. There's lots of ways to deliver medicines to treat symptoms where you don't have to be in a hospital and you can stay in your home. But technically, it's an insurance benefit that pays for this type of care when a hospice medical director and a referring physician both agree that our best guess is that the life expectancy is 6 months or less. Does that make sense? Anything to add?
Just one that
Yep.
In volunteers, it's difficult sometimes. I work for two different agencies, and they always need the volunteers. And I think one of the things that I've encountered and they've encountered frequently is that people are afraid to volunteer because they don't know how they're going to respond if a patient is in the last few moments of life. But you get a lot of training and a lot of help in that, and you don't get dropped into one of those situations.
Yes.
One of the things that's really important is to be with the family and to give them a break now and again.
Right. Exactly. Thank you for sharing that. Yeah, so it might be another potential action step down the road is consider being a hospice volunteer. So how do these fit together? I think this was a specific question when we started this morning. So how do palliative care and hospice sort of interface? Well, the old school approach, the way it used to work, tended to wait too long for the benefits of palliative care. So, for example, when I was a medical student, we were really taught that someone's diagnosed with a disease and it's full court press for cure, and then at some point it's like that switch is turned off, and then we go straight to palliative care, which is only focused on symptoms and no longer pursuing cure of any kind. And then eventually folks kind of hit the 6-month life expectancy mark and they go into hospice, and then the bereavement support is there for the family. Well, the way medicine is moving and moving quite aggressively today is really this parallel approach that folks can be diagnosed with a chronic illness like heart failure or cancer and begin to have symptoms that would benefit from this team of folks who are specially trained to provide symptom control and emotional support and spiritual support. At the same time, you're getting your chemotherapy for your cancer, that those two really should go together. Does that make sense? And then at some point, if you're not cured of your disease and the body begins to slow down, then folks will hit this time where their life expectancy may be 6 months or less, and then they can transition into the hospice benefit, which essentially provides the payment for the care to continue to come and into the home. And then eventually we all pass away and the bereavement support is there for the family. Does that make sense? Kind of the aspirational model is that these are even further intertwined, because like my friend who I met with who's recently been through her first round of chemo, there's some grieving that goes with that diagnosis, right? And some instant change. And there's need for bereavement support and healing, and not just physical healing. You know, the veterans I shared the stories with, they need a lot of spiritual healing, maybe from the time of diagnosis or even before diagnosis. So the idea is that we're pursuing curing and healing along the way with that support at the same time until the good Lord calls us home, and then there's that support for the family. Does that kind of make sense? Does that answer the question of how they kind of fit together?
Yeah. I just have one other.
Mm-hmm.
In a memory unit, and it seems like they don't have end of life, and it's obvious there that people need that person to be killed.
Uh-huh.
Is that a federal law, or is that a hospital or a nursing home law?
So are you saying, explain again?
Well, this process, I could see it going on for 6 months,
Uh-huh.
but I think I would be told it's time to move her to skilled nursing. Is that
You mean if she starts to develop a symptom or a problem?
Yeah.
Yeah, it's a good question. So hold on to that thought, because I think I'm coming to it actually, and we're going to loop back around there. So how does palliative care provide relief from this suffering? Because when your wife develops a new symptom, that's a form of suffering. It might be a physical symptom. So how can palliative care come in and help with that and help make that decision about, well, would there be a benefit to going to skilled nursing to have that managed, or to staying in the memory care unit? Well, the first part gets at the initial answer to your question. Doctors still struggle sometimes with having the conversation around what is a patient's and family's overall goals. You know, what is the actual stage of someone's disease? What is the prognosis? And what is the patient's goals? And that's a key first conversation to have, because that will help guide the decision. Is this a benefit to go over to skilled nursing or to go back to the hospital or to go to the emergency room? Because the overall goal is to pursue these types of interventions because this is a symptom that could be reversed. Or is it a situation where we're having the same symptom over and over again, and those trips to the hospital or those maybe more aggressive therapies are more burden and they're not providing any benefit? So the first step in answering your question is an area where the healthcare system still struggles a little bit. It's just kind of stepping back and saying, you know, what is the prognosis? Where are we on the illness journey? And then what are the goals? And then what's going to be beneficial versus burdensome? So this is an area where doctors tend to still struggle, and where a palliative care team member has training in having those conversations. So one question to ask in a hospital or a clinic or a memory care unit would be, do we have palliative care here at this facility? Is there someone I can talk to about sort of the big picture goals? Yes, sir.
How much of that is a function of our medical practice having divided itself out away from the spiritual concerns and dealing primarily with the physical, organic kind of thing, when in fact that's not actually treating us as human beings?
It's human beings, exactly. It's treating you as a heart, as an organ.
Yeah, it's kind of an organic machine.
So the good news is, so when I was in training in medical school, it was exactly what you're saying. It was very organ-centered, disease-centered. It was not person-centered. The curriculum across the country in the last 10 years is really moving more towards this model, towards person-centered. It's really with the birth of the field of palliative care. So medical students, residents, physician trainees, nurse trainees, more and more are getting this type of training out of the gate. But we're going to have a gap out there because we've got a bunch of folks who have been working in healthcare who never got this training. So this CAPC organization, their mission is to provide this type of training as fast as possible to as many hospitals and healthcare systems as possible. So that's where we're going to need to kind of advocate for our loved ones to initiate these conversations, and it's the right thing to do. If you're having concerns about my loved one is going back and forth to the hospital and nothing ever seems to get better, that doesn't mean that it's not the right thing to go back to the hospital, but it's time to start asking questions, you know, well, what's the big picture? Where is my loved one on their journey? What's their prognosis? And the literature tells us that families want to know the prognosis. Yes, ma'am.
So do the majority of hospitals now have a palliative care unit?
Many. I do not know if it's the majority. I'll tell you, when I did the Google search for St. Louis, every single health system it looked like in town had a palliative care program. Yeah, and I've put those numbers and websites in your booklet. And it's not an all-inclusive list, but I just hit kind of the big ones I recognize just right down the list.
Will you have to ask for it? You have to ask?
Ideally, you would not.
Okay.
But because this training is still not touched every doctor and nurse out there, I would encourage families to not be afraid to bring up the question. And typically it's just like, you know, my mom's been in the hospital 3 times in the last 6 months. We keep coming back with the same problem. I know I've been told, you know, her heart is failing, you know, hey doctor, where are we? Can we sit down and just have a conversation? So doctors struggle because they went into medicine to heal people. So cancer doctors I've seen really struggle the most. And you want your cancer doctor to be, you know, full court press in the beginning, but at some point you want your cancer doctor to realize something's more burden than benefit. So doctors are humans too, and it's hard for doctors to lose patients. So sometimes they need our permission. And that's what some of these studies have shown us, that these families wanted physicians to discuss their prognosis even when the doctor's not certain. And I'll tell you, the other reason the doctor sometimes doesn't bring it up is because only God's in control, and they're afraid they're going to tell you something wrong, or they're afraid they're going to dash your hopes. But the reality is, only by just openly communicating what you're observing and what the potential journeys might look like, we're allowing families to have realistic hope, and to plan. And the same for the patients. And the patients will tell you, I want to know what's going on. But there are still many physicians who are just afraid to have this conversation. But if we give them permission, they'll do it. Does that make sense? Yes.
Can you talk a little about where gerontologists come into this picture, or is that further on here?
So geriatric physicians are really always practicing palliative care. And really every physician should also be trained in practicing palliative care. Gerontology, the field of gerontology, are not clinical providers. So so a geriatrician, a geriatric physician, is someone who went to medical school and is actually delivering patient care. The field of gerontology is more in the behavioral science realm of geriatrics, so they're not clinical providers.
They're all geriatric physicians, is that?
Yeah, so I'm a geriatric physician. So there are doctors out there who did special training in the field of geriatrics. And obviously geriatrics has a lot of palliative care, delivering palliative care.
So, for instance, if I'm in my 80s, I get a cancer diagnosis, I was already an oncologist, should I also look for gerontology?
Not necessarily. So there's not enough geriatric doctors for everyone to see, just kind of because folks turn a certain age. The best use of the limited geriatric doctors that we have is for folks who are having a specific issue like dementia that requires sort of that specialized training around sort of managing dementia or some of the complexities that go with that. And even with that, there's not enough geriatric doctors to see those folks. So one of our missions in the field of both geriatrics and palliative care is to train every other healthcare provider to deliver this type of care. Because really these things, as if we all live long enough, we're all going to become geriatric. And clearly, the one thing that's certain is we're all going to pass away from something. And so we're all going to walk through this end-of-life journey, and the goal is to have healing along with that, physical healing, emotional healing, spiritual healing. Doug, do you have any comments around that journey?
Yeah, I'm just thinking a couple of things. One is that a lot of what we talk about today, not purposely, death is the most awful thing that ever happened to human beings. In the Christian worldview, death is awful, but it's also amazing. Mm-hmm. So the whole world is afraid of death. They do everything in their power to stave off death. Death is just the most, the worst possible thing for a Christian. They sing their death song, even amidst pain. So there's a lot to that, and I'm not trying to minimize the fact that suffering is awful, right? But there's certain worldview presuppositions which underlie all this kind of stuff, which the Christian community has something unique to say, right?
Yeah.
I'm ready to die now.
Yeah, right.
Seriously, I
right.
would like to die now and go be with Jesus.
Right.
I don't want to suffer necessarily, but I want to sing my death song. I don't want to hang on to this life with everything I've got. So that's a whole big, huge topic. We'll have another class on that.
Yeah. But thank you so much for saying it, because again, you need a palliative care team if you happen to be someone who is particularly experiencing certain types of symptoms. Lots and lots of folks pass through their end-of-life journey, go home to be with the Lord, and don't have a lot of symptom burden and don't have a lot of suffering. Those around them are celebrating them being with the Lord and also grieving that loss. That's very normal and natural. So again, it's the same thing with dementia. There's lots of variations in this. And I'll also tell you, now I live in the Bible Belt, so these conversations are very, very common. Lots and lots of folks are super excited about what's awaiting them. I see it every day. There's a lot of joy in this journey that I see daily. It's very real. Somewhat to the point where they're frustrated with me that it's not happening sooner. I've had those conversations multiple times, and our role is not to speed things up or slow things down, but to walk alongside folks during the journey. But I see hundreds of people who are ready to go home and be with the Lord and are wanting me to do my part in that. So we're there to walk the journey with folks and provide that prayer and support.
That's another thought. I'm curious about this. The word pallium, from which you get palliative care, means cloak or something like that. I wonder if this is part of the definition, but like a pope wears a cloak to dignify and distinguish. I mean, it's not so much, it's not armor.
Mm-hmm.
And I just wonder, from a Christian perspective, a lot of palliative care is about confirming human dignity.
Yes.
In other words, recognizing the infinite worth of human beings, that Jesus Christ would become one, live, die, and rise for us. So, from a Christian worldview, the cloaking is a dignifying, which our culture is not good at. In fact, we're increasingly, in Missouri actually, something was just passed that opens the door to euthanasia. And we're legalizing physician-assisted suicide and all that kind of stuff, which is to rip the cloak off people.
Right.
You're not dignified. We'd rather allow you to. So that's another uniquely Christian aspect of this whole conversation.
Absolutely. And the field of palliative care is opposed to euthanasia and physician-assisted suicide, because we're really about bringing dignity and healing. So these are the types of decisions that patients and families, all of us, will need to make at some point for ourselves and to help our loved ones. And some of this is the first question that was asked: at what point, how many more medical interventions, especially those that are maybe invasive or burdensome or might have risk to themselves, at what point? And the way I think about it, and the way I think it's helpful for all of us to think about whether we're in healthcare or not, is something going to be more beneficial than burden? And at some point, that scale starts to tip, and that's a conversation to have with doctors, and is very unique to that one particular patient in that particular stage. It's not like a cookie cutter type of conversation. Does that make sense?
I had a conversation yesterday with me and her doctor, who is a gerontologist, on every one of those questions except the last.
Good.
Question did not come up. Basically, she has told both of us the end of life stage is that pretty bad. The worst is that is when the thing is going to be and I know then I see the word okay yes, but behind my thought I want to say memory care, but
Correct.
basically would be getting the same thing, I would say.
Yeah. Was it helpful to have that conversation
Well,
with the doctor?
yes, but it wasn't the first time.
Okay, good. Right. Right. Right.
And now it's heart issue. Opposed to doing anything like pacemaker.
Right.
Just to extend life and not having something.
This is a great example of, these are really not just one conversation, but they're ongoing. And with each episode is another time to have the conversation. And the question to ask would maybe be, is palliative care available in this facility? Is this some folks that could come alongside? And the other question might be to ask, if it didn't come up, is she appropriate for hospice yet or not? And that would be a question to ask back to the doctor there, to help guide these ongoing discussions. Yes, sir.
One of the things that I've seen in the nursing facilities that I've been volunteering at is how important it is for them to perhaps 12 when they're saying, well, they're not drinking, they're not eating, they can't do this, then they say, well, within the last 24 hours, the body starts to shut down routinely, and these are some things that are expected.
Right.
Normal, you
Right.
shouldn't be concerned about it, and that makes a
Big difference. And it gets at that first graph where patients and families want to know what the dying process looks like so they know what's expected and what's normal.
And anxiety. What can I do?
It does. And so in our current healthcare system, many times we as family members need to initiate those conversations. Those conversations should be happening automatically. They are not consistently. And I think one of the reasons to have this conversation today is to empower you all, if you're in this situation or if you will be in the future, to feel empowered to ask those questions, you know, and ask the doctor to sit down with you and have these conversations. And the preferred location of death kind of gets at the idea that most patients will tell you, I don't want to die in a hospital hooked up to tubes. I want to be sort of where I live, whether that's a memory care unit or my house or wherever, with my family around me. So these are a very common type of symptoms. So there's no symptom that can't be addressed by palliative care or hospice team. And as mentioned, we have all kinds of ways to deliver medicines that don't require IVs or for folks to swallow. But it's a team of folks who are very proactive and always for looking for what we can do. So what we're trying to train our students and doctors to never, never, ever say is there's nothing else more we can do. There is always something we can do. I cannot cure Alzheimer's disease. If I could, I would do it tomorrow. I cannot cure Alzheimer's. I can always care for my mother, right? And I can always care for my patients. And I can always deliver relief from symptom burden, even if I can't cure lung cancer. So we're really trying to train our docs to be proactive and look for these symptoms and treat the symptoms. And then we call on our other team members, there's one of our music therapists, to provide that ongoing support for the patient and family. And because this type of care really is whole person care, and it really is about healing, it's not uncommon for folks who start receiving palliative care to actually live longer than patients who were just as sick and who kind of stuck with the chemotherapy. This was a landmark study in lung cancer patients about 7 years ago that basically demonstrated if you have lung cancer patients who were at the same stage of their lung cancer, so pretty advanced stage, and some said, well, this chemo is not going to cure the lung cancer, it's really making me feel lousy, it's really sick, it's toxic. I want to pursue managing my symptoms and have the palliative care team join in. Those patients actually lived longer than the lung cancer patients who kept getting the chemo. So really providing less toxic care and getting at, again, what's beneficial versus burdensome. Sometimes we're actually extending life expectancy and it's a much higher quality of life. So when should we think about asking for palliative care? And this gets back to your initial question, and what you're describing is the exact time to ask. So why are we going back to skilled nursing? We keep having these recurring symptoms. At what point is going back to skilled nursing no longer beneficial? Those are just the type of questions to ask and to keep having this ongoing conversation. So we do think about it for these things we've kind of talked about, including this assistance with complex decision making. That's a complex decision. You know, in this situation, going to the emergency room might be helpful. In this situation, it might not. So those are complex decisions. They're very unique. That's the time to ask about, was this something a palliative care team could help us with? Or do you have palliative care in this hospital or in this clinic? Or how can I get access to palliative care? Or is my loved one now appropriate for hospice care? Does that make sense? So any type of symptom control, frequent emergency room or hospital visits that just don't seem to fix the problem, or if your loved one or someone is in an intensive care unit and the doctors are saying there's really little to no hope for meaningful recovery, that's the time to just ask, well, is there access to a palliative care program here, a palliative care team member? So palliative care can be delivered in all sites of care. The extent of what's available really is unique to each health system in each city. Now, because there's been such a push to develop palliative care programs over the last 10 to 15 years, they are pretty common. And I've got phone numbers and websites to all the major health systems I found in St. Louis. And what I noticed is some tended to have, it looked like they had more hospital-based programs, some had clinics, some of the nursing homes probably have palliative care. So it is still a little variable on if a health system has a hospital program versus an outpatient program. But the numbers are there for you to call and ask. Hospice is very well established. So I obviously did not put on your handout all the hospice agencies in St. Louis because there's a lot. So hospice is very widespread. The degree of palliative care programs is still variable, but people will know what you're talking about if you ask about palliative care. Yes? Yeah, that's also unique to the setting and to the state, so I would ask about that. So the palliative care delivered in the hospital is very much covered. And then there's some uniqueness in the coverage to get a palliative care team in the home that's not the hospice benefit yet. So that's something very specific to ask your doctor, your social worker about your loved one. But those coverages are expanding. So we have an option for some Medicare HMOs in Alabama, not for others. It's very unique and quite complicated. But yes, sometimes it is. Yes?
St. Luke's has a hospice program that they cover.
Yes, perfect. So you really just want to ask, now hospice in general is uniformly covered by Medicare and most private insurers and even Medicaid. To get kind of the more upstream, so maybe a patient has 2 or 3 years life expectancy. That would require a specific question to ask about, do you have palliative care and what's covered and where is it covered? Does that make sense? But the nice thing is, and the idea is to expand the coverage for these types of programs because they're clearly the right thing to do for patients and families, and they're clearly cost saving as well, which is what the payers are interested in. So it's a win-win. So this is the CAPC website, the link for you, and they have information specifically about caregivers. So the getpalliativecare.org is palliative care information for caregivers to learn more about palliative care and how to get palliative care. So this is the caregiver portion of the CAPC website. So if you just kind of Googled getpalliativecare.org, and on this website, amongst all those different materials, it talks about what is palliative care, how do I get it, is it right for you? They have a little like 5-item quiz to see, was palliative care right for me right now, or is palliative care right for my loved one? So it's 5 simple questions. You can actually do it on the website. You click in the answer. This is just the first question. Do you or your loved one have 1 or more serious illnesses such as, and it lists cancer, congestive heart failure, lung disease, kidney failure, liver failure, and then dementia is listed there. And you just click as 1 or as many as you or your loved one has, and then you go on to the next question. So the next question asks about symptom burden. The next one asks about side effects and healthcare utilization. This would get at the question for your wife. Are we having side effects of medicines? Are we having lots of needs for extra healthcare utilization? Benefits and burdens of treatments. And then coping support and resources. It has these kind of multiple choice questions. And you can just go through the quiz, and then it'll tell you at the end, well, this might be a right time to ask about palliative care for you or your loved one. So that's kind of a helpful tool to kind of guide. Am I on the right track if I'm thinking about if I should ask about this type of support? Let's do our quiz again. Once you elect palliative care hospice, you can no longer see your primary care doctor or subspecialist. That is false. So even under hospice, a lot of times it's your doctor who is your hospice doctor. If it's something related to providing symptom relief, you can still have access to those doctors. And for sure in palliative care, many times you're still pursuing aggressive therapies. Receiving palliative care means you can no longer receive curative treatment, so that's false, right? Because the palliative care really is about supporting you through your illness. That's really all it's about. Hospice patients must be do not resuscitate. I don't know if we specifically addressed this. Technically, you do not have to be do not resuscitate to be on hospice. And so if that's a difficult decision for a person right now, but they can clearly say, well, I know my life expectancy is limited. I really want the support that hospice brings. They can decide later, if they want to not receive CPR or intubation. Those things usually kind of work themselves out, so technically you can still get hospice. Palliative care and hospice are appropriate only for those who are going to die soon. Yes?
I heard the other day that somebody came out of hospice.
Yeah, so you can come out of hospice really at your choosing. I've seen patients get better with the support of hospice, and they no longer need hospice anymore, so they come out of hospice. Or if you decide you do go back to the hospital, you sort of come out of hospice at that point. And then when you leave the hospital, if you say, well, I really want to get back into hospice, if you're deemed appropriate, then you can go back into hospice. So it's not uncommon for folks to kind of move in and out of hospice. Right? You've experienced that too. So clearly the idea of palliative care is to be upstream in the process to provide that support, maybe even from the time of diagnosis, especially if there's symptom burden. And then the hospice benefit does provide counseling and support the family after the loved one has passed away. So it's really a benefit for the family as well as the patient. Did we answer the questions around what is palliative care? And what other questions do you have? Yes, sir.
A lot of facilities have chaplains. How soon are they introduced into the process? Is it immediately, or, and I'm sure it varies, but obviously I would think you would want to include it as soon as possible.
Yes, yes. So that the whole team's on board from the beginning.
Okay, so they are part of the team going in.
Yes.
Initially.
Yes, and then it's really kind of patient-family goal specific as well. So not everybody needs the whole team all the time. So it's really individually centered around what are the patient's goals and desires and wishes, and we're here to honor that and support them. But from the very beginning, the entire team is a part to try to develop kind of the care plan along with the patient and family. Yes, sir.
Hospital set up that way?
So the extent is variable. Yeah. So because our palliative care team also happens to have counselors, music therapists, pet therapists, art therapists, not every palliative care team is going to always have access to all those folks. Yeah. Yes.
So I know you face this in your professional associations and things. So you mentioned euthanasia as assisted suicide, which when we enter into those debates, the other side, which is advocating for those as treatments, they see those as caring, the most caring and loving alternatives. Or in a Christian worldview, we see those as evil things.
Mm-hmm.
How do you engage that discussion?
It's a great question. So the intent may be to relieve suffering. The question is, we can relieve suffering and honor the person and preserve dignity by doing these other things. Does that make sense? And a lot of times what I see is sort of jumping to that decision without doing any of the other things that we've talked about today, which is really providing healing more than just kind of physical symptom relief, and allowing even that time for patients and families to have healing around other things besides the illness.
And you touched on something really significant, and that is that frequently patients who go into hospice, and if they would choose the end-of-life option, sometimes these patients recover and go back.
Yes. Yeah.
So
yeah.
You're jumping the gun.
Well, and there's so many of those medicines that, like chemotherapy, that are designed to cure are really causing a lot of symptom burden and a lot of debility. And just kind of freeing people from these very invasive medical things is actually healing in a way for some time.
My question isn't the assisted suicide murder to a degree? I mean, we're helping someone die or, being a part of killing someone. Although I give them the right, I guess is that how they get out of it? Because I give them permission to kill me? I mean, I know that's a slippery slope.
Yeah.
I mean, how could a doctor who actually his profession is to heal and extend life be called a doctor when now he's helping to kill someone?
Yeah, and I'm not sure what's kind of going on in the rationale of those folks. My role is to provide support and relief from suffering of all the domains throughout the person's journey, and that journey is completely out of my control. And the patients and families that I talk to using that language, we are here to support you and walk you through your journey. We are not in control of that journey. That is not our role. Our role is to walk with you every step of the way and to support you and your family and very aggressively treat any symptoms that come up. 100% of the time, my patients and families are like, yes, that's what I want. That's what I've been waiting for somebody to tell me. Even if before we had that conversation, they're thinking, I'm in so much pain, I just want this to be over. It's because no one's come along beside them and really sat down and had the conversation. What are your symptoms? How can we address your symptoms? What are your goals? How do we get to the goal? And support you every step of the way. And I intentionally use that word journey. This is a journey. We're all on this journey. And my role is to come alongside and walk with you every step of the way of that journey. And the journey we're not in control of. And I see the stress just immediately. Like, I see the body language change. Because these folks have been just shuttled from place to place and medicine to medicine and test to test. And it's just sitting down and having that big picture conversation, about what do I want this to look like and how do we get there? Does that answer your question, Doug? Kind of? Yeah.
This is a huge another topic.
Yeah.
And there are others like Jay Whipple who talk a lot about this. But one thing that's very interesting is I think we put too heavy a burden on doctors to have answers to things, well, all kinds of things, but especially moral, spiritual things. And part of that's because the church is not speaking about this.
Mm-hmm.
And the church's only authority is moral and spiritual. So if the church isn't speaking clearly about life issues, the value of life, the value of suffering, the ultimate goal of life is to know God, just those kinds of concepts. I know, and I've walked through this with my own family members, where you're in a crisis mode and the person has a chronic illness, and the first person they ask on what to do is the doctor. And the doctor, if they have any moral compass, will give some advice with a moral compass. But if they don't, they won't.
Right.
Which is why OBGYNs say, well, if you have a preborn child who is diagnosed with Down syndrome, you should abort the child. That's appropriate medical care without a moral compass.
Mm-hmm.
So
right.
This is a catalyst because I think increasingly we're going to not only have these challenges on what kind of care we look to, but we're going to have to be equipped to engage a culture that increasingly sees death, suicide, physician-assisted suicide euthanasia as the solution.
Right.
We're operating on a completely different worldview. Because everything you've talked about assumes a Christian worldview. Everything you've talked about. But if we have a doctor who's from India and is a Hindu, he's not going to share half of those values. And that's increasingly becoming true, I think, at least around what I've been told. So if you're on a palliative care team, Jay Whipple, the doctor, head of radiology, I think, at Barnes, Washington Medical School, he said he was on some of these teams, and a patient, they have a team approach to treating a patient with a complex illness. And he said he was shocked. He shouldn't have been shocked, but he said he was shocked when he was the only one in the room of medical professionals who was providing input in the treatment protocol from a Judeo-Christian worldview. because the Hindu over here and the Muslim over here and this other doctor, they don't have these same assumptions. So now we've got a whole other complex issue with these kind of prescriptions. So I'm not trying to make the water more murky. You know, that is my last name. But because you've done a fantastic job, I just feel sorry for doctors sometimes. You got so much pressure to be the answer person. And I just would love to see the church continue to grow in its ability to address these things from a moral, spiritual standpoint.
Well, and it's why this is delivered as a team, and we desperately need the church to come alongside and help us.
Yeah, like you're here in a church today.
Right.
We've got memory care buildings going up in our
Right.
community like crazy. You know, this is huge.
And there's not enough of us out there to do this on our own. I mean, one kind of action step, I've kind of said it a couple of times, we've got to come out of here that we're in this together. And remember, from the very beginning, we're all healthcare providers. I just happen to get paid to do it. And some others have been paid to do it. But we're all in this together, and it's a ginormous mission field out there right now. Yes, ma'am.
Yeah, on the theme of all in this together, I think that does include the Hindu and the Muslim, the Sikh and so on, who may not share, certainly not share our ultimate worldview, but I think it'd be, in our conversation about all this, I think it behooves us to remember that they too want to alleviate suffering. And so with suicidal and so on, instead of thinking it as only evil, if we step into their shoes and if their motive is to alleviate suffering, and then like you said, but there's a, thank God, we're moving into providing an alternative answer to that. But I think that, to attribute evil motives, I don't think helps us in our conversation.
Yeah, it does. Yes.
I learned recently that even though we on the outside tend to think that they want to die because they're in pain, that that's really not the highest on their list. But the highest was autonomy, that they don't have the choice or the ability to do what they want to do in life. So we tend to think, oh, kind of thinking, but that's not even at the top of the list for those who are usually seeking and
And one of our roles, we talked about it earlier, that patients want to have control. That can be control over what time we eat breakfast. I mean, for all of our patients, whatever they're physically able to have control over, we're very intentional about allowing them to have control. So it just might look different. I even go back to the dementia video. Josephine is still an artist. It just looks different. I was walking along a beach in Florida this past October, thinking about a talk around mobility, and I saw this delightful family with their loved one who was wheelchair bound at the beach. So this woman can still go to the beach, it just looks different. So, as much as we can still give people control, even though it might not be look the same way they had it when they could get up and walk around, that's very important. And nursing homes are getting better about this. They're moving away from, okay, everybody's going to eat breakfast at the same time at 8 o'clock and we're all going to the same room. Well, that's not how we lived our lives. We kind of got to pick when we woke up and when we ate breakfast. And so institutions are moving towards allowing that type of control because that's a quality of life. That's a dignity issue. I mean, if we've lived our whole lives, we've earned the right to kind of pick out what we want to wear and decide when we want to eat breakfast, right? That's a dignity issue. So I see the healthcare industry moving in that way, but it's still not across the board yet. Yes.
Sweet memory that I had from hospice care was when my mother-in-law was staged for her cancer. is something that the family would really like to have done themselves, but emotions and just the whole experience, just volunteered to work for us. And she had a piece of paper to ask questions like what hymn she wanted at her funeral service.
That's great.
What she wanted to be laid out in. What dress did she have? Was it we go out, buy something new? She went through all of these steps that we were very thankful to have that paper when the time came. But when she got all finished, she sat at the side, they had this conversation, she said, "Would you like a manicure?" And my mother-in-law said, "Sure." So they ended their session getting her baby.
Perfect example.
So, but it was so sweet.
Yeah.
And such a benefit.
And isn't that allowing your mother-in-law to have control over that entire experience? From did she want her nails done to what do I want my funeral to look like?
We were taught
Yeah.
the situation of we put our hand out.
Yeah.
If she wants to put her hand in, move it.
She'll do it. And that's control too. It's not this, let's just go and grab people from under their arm and tell them to stand up. You're going to get to the same endpoint, but you're going to allow them to still have some control. Yeah. Any other questions? That's all the prepared materials. It's really just your time from here on out.
I just want to thank everyone for coming, and especially Kelly. We are videotaping this, and this will be on the Facebook page of our YouTube through the Twin Oaks website. So you can just go to Ministries, Life Team. There's a link on that page to our YouTube. And also, finally, Kelly's going to be teaching tomorrow at 9 a.m. in our Sunday school class. And she's going to be talking about dementia again. So if you'd like to hear her again, or if you want to encourage other people concerned to attend, I would ask you to do so. Again, thank you. And then Doug's going to close us in prayer.
Yeah, I want to pray for you especially. And I want to also just